Okay. The second part of the vascular pathology, arterial diseases, I think I have couple of slides which I should start again. I think I didn't
Recording in
finish
progress.
that part. And I hope that you have gone through the risk factors of atherosclerosis in your medicine book, right? So just to go through in brief. So atheromatous lesions increase in number with age, and it's more common in males than females, and there can be familial traits. So their age, sex, familial traits are considered non-modifiable factors of non-modifiable risk factors of atherosclerosis because you can't change them. The major modifiable risk factors are the hyperlipidemia, hypertension, diabetes, and cigarette smoking. Then other factors like lack of exercise, overweight, stress, and your own personality also can be risk factors to develop atherosclerosis. And moderate consumption of alcohol is said to be slightly beneficial, but it does not mean that you're free of any other problems that are associated with alcohol. And these are a few things that I am just going into, but for medicine and also for your biochemistry, I'm sure you have learned all this. So LDL, which is the richest in cholesterol, if the patient is having high LDL levels, they are at high risk of developing atherosclerosis. Then VLDL, which contains more triglycerides, and if somebody is having HDL, high HDL, that is very protective. Then patients who are having hypertension also there's a high risk of developing atherosclerosis. The reason is that because of different currents in the blood flow can cause a mechanical injury to the endothelial cells and therefore endothelial cell dysfunction. Then smoking, which reduces your HDL level and which causes accumulation of carbon monoxide, and the endothelial cells become hypoxic and can get damaged. So that is again a risk factor. And diabetes mellitus is also considered the risk factor for atherosclerosis due to not only single reason, it's a bit more complex. So this is from your book, straight from your book, major risk factors of atherosclerosis. So non-modifiable or the constitutional ones include the genetic abnormalities, family history, increasing age and male gender. Then modifiable ones are the hyperlipidemia, hypertension, cigarette smoking, diabetes, and inflammation also has been included because maybe a decade ago they identified that there is some association with inflammation, and they used to describe atherosclerosis as a chronic inflammation and repair process. And there were a lot of reports saying that there's chlamydia infection which is associated with development of atherosclerosis, but the evidence is not as solid as it was expected to be. But inflammation definitely is playing a role in pathogenesis of atherosclerosis. The other additional factors are homocystinuria and metabolic syndrome, which are causes of endothelial dysfunction. In cigarette smokers, they believe that smoking affects coagulation system, and it decreases endothelial prostaglandin 2 and decreases nitric oxide synthesis, and platelets become more sticky and alters the blood fibrinogen level. So the pathogenesis of atherosclerosis in a chronic smoker is a sort of a complicated network of effects, right? But if you know that cigarette smoking is harm, that's good enough, right? Let's move on to today's lecture. That's the other diseases affecting the vasculature or the artery especially. And I hope somebody asked or we discuss about aneurysms also. And aneurysm, by definition, it's an abnormal, permanent, focal dilatation of an artery. So all these parts are abnormal, permanent, and it doesn't reverse. It doesn't get reversed, and it's focal nature, and that is a dilatation. All that is important when you are defining what an aneurysm is. So there are several types of aneurysms. The most common are due to atherosclerosis, so that they are called atherosclerotic aneurysms, and I have already told you that they are more common in the lower abdominal aorta and also in the iliac arteries, because atherosclerosis is most commonly seen in the side. So they can present as a mass, abdominal mass, which is pulsatile because it is within the artery, the biggest artery in the body, the aorta, and it presents, or it is clinically found to be a pulsatile abdominal mass, and it can cause lower limb ischemia. We will come to that later, why you get ischemia when there is a dilatation in the aorta. Right. Then rupture, which causes, it can get ruptured, and that can cause massive retroperitoneal hemorrhage and patient can die. Other examples are, I hope you remember from your anatomy days, berry aneurysm, which occurs in the circle of Willis, that is intracranial aneurysm. And when the circle of Willis, the berry aneurysm rupture, it results in subarachnoid hemorrhage. So the hemorrhage is between the thigh and the arachnoid. Then microaneurysms can occur in this berry aneurysm occur in the brain, and also microaneurysms can occur in the brain. Those microaneurysms are called Charcot-Bouchard aneurysms. They are seen in intracerebral capillaries and small arteries, and those again can rupture and can cause intracerebral hemorrhage. And while they rupture, they are associated with hypertension, and the aneurysms, although they are dilated because the vessel wall is weaker, and they can easily get ruptured and cause massive hemorrhages here, like in this case. But here also it can cause intracerebral hemorrhage and a lot of effects within the brain. Then syphilitic aneurysms. The syphilis, for your chronic inflammation, I hope you learn. Syphilis is a chronic inflammatory process, although advanced stages of syphilis is not seen because of the treatment, the antibiotic that is available, and then they are screened. More prone people are screened for syphilis. Therefore, the cardiovascular stage or the tertiary stage of syphilis is not often seen. So this is a bit historic when it comes to syphilitic aneurysm of the aorta. And syphilitic aneurysms occurs mainly in the ascending part and the arch of the aorta. Therefore, they are sort of presenting as mediastinal masses and causing a lot of problems, and they can have aortic incompetence. We'll come to that later why it happens so. Then mycotic aneurysm or infective aneurysm. Although they are called mycotic, remember this is nothing to do with fungal infection. Probably in fungal infections it can happen if the vessels are involved, but mycotic here is not regarding any fungal etiology for all these mycotic aneurysms. Mycotic aneurysms occur due to an infective etiology, maybe bacterial. They are common in the root of the aorta and can potentially can affect any vessel. So they can rupture. Tiny mycotic aneurysm can rupture and cause bleeding. They can be associated with thrombosis and cause cerebral infarctions if it happens in the arteries supplying the brain, and or hemorrhage. So these are the common types of aneurysm. Right. So morphologically, aneurysm can look like can have different shapes, fusiform or saccular. Saccular is when the aneurysm develops from a focal. Now, if you take the circumference from only one part, it develops. One part it's weak and it balloons out. That's what has happened here. The full circumference of the vessel wall is not affected. So it takes a saccular shape. If the full circumference of the vessel involved is affected, it gives rise to a fusiform shaped aneurysm. So what is the pathogenesis of aneurysm? The wall is weak. The vessel wall which is affected is weak due to some reason, probably congenital, like in the case of berry aneurysm, or maybe acquired due to atherosclerosis or syphilis causing aortitis or some other infection. So when the wall is weak, it has the tendency to balloon out, forming an aneurysm. So congenital ones are also due to some weakness in the wall. So what causes this expansion? Now, if you take the vessel wall like this, now if some part is, this part is weak, it starts sort of becoming bigger, right? Because of the blood pressure, pressure keeps on having some effect on all around the circumference. But if this part is weaker, it sort of tends to get expanded like this, like that. So you get a big bulge out like this. But if the whole wall, the full circumference is weak, you get a saccular one like this. This is like this. So that's a aneurysm. Right. So the weakening can occur, I have already told you, it may be a congenital problem or maybe due to atherosclerosis compressing upon the media, causing destructions, and the vessel wall gets weakened, and therefore it expands due to the pressure. So people who are having high blood pressure are at a risk of developing aneurysms. So those are contributory factors. Okay, so let's take atheromatous aneurysm, the first one. They usually occur after the age of 60 years. It's not common in young people and more commoner among males than females. And most of them are having hypertension. Obviously, hypertension or the blood pressure plays a big role. If the pressure is high, the pressure is exerted upon the vessel wall. If the vessel wall is weaker from that point, it starts sort of expanding into the periphery, and it becomes weaker and weaker as it expands. Then they are usually fusiform. The atherosclerotic aneurysms in the aorta are usually fusiform, and the media of the vessel is weak due to the extension of the plaque into the media that I have already told you about. Then commonest site within the abdominal aorta is the part of the aorta distal to the origin of the renal arteries, fortunately, right? Other arteries involved could be common iliac. And what are the effects? Now, aneurysms can have pressure effects, but abdominal aneurysm causing pressure effects is not so common. But the major problem is mural thrombosis. Very out of the way question being asked. Can coronary artery atherosclerosis effects to increase the vegetation in? I don't understand what it is. Probably at the end of the lecture I shall discuss this, right? Okay, so back to your atherosmatous aneurysm. The major problem is mural thrombosis. Why do you get mural thrombosis? Now there is a dilatation. So why we were wondering why shouldn't they get ischemic results? No. So if this is the aorta, there's a bulging like this. Let's come like that. That's the aorta. Right. Your blood flow is, that's bad. Blood flow is along this direction. So as you know, axial flow is the one which is going faster, but towards the wall it's slower blood. So there is some amount of stasis within this bulging. Therefore, layer by layer, thrombosis or thrombus formation occurs over this aneurysmal dilatation. So there is thrombosis that it can continue, so that some of these parts can get detached and become embolized and get distally impacted, causing ischemia. So mural thrombosis that occurs due to your work of the stasis. The stasis plays a bigger role here, causes thrombosis within the aneurysm, and those parts of the thrombi can get detached and cause embolism, and those emboli can cause distal ischemia. The other important thing is this happens over a long period of time. So the ones which have formed, the layers of thrombosis that has formed over this wall more in contact, the ones which are more in contact are the older ones, and they may have undergone organization by the time the others get formed over that surface. So in an old aneurysm, you will see very pale areas, and then only you see the reddish plaque here towards the lumen. So that's how it occurs. But when these things are happening, the dilated aneurysmal wall doesn't become stronger, it becomes weaker and weaker, so it can rupture and cause massive bleeding. There's a question asking, can mycotic infection cause aortic incompetence? Now we were talking about mycotic aneurysm. We will talk about them later, otherwise others will get confused, right? Right. This is the aorta, and that I said this is the kidney, and I said the common site of aneurysm, development of atherosclerotic aneurysm in the aorta is distal, generally distal to the origin of the renal artery. So this is an aneurysm. So an atherosclerotic aneurysm of the aorta just above the aortic bifurcation. Now that's a bifurcation just above, but below the renal vessels. They're prone to rupture when they reach about 6-7 centimeters in size. They most likely have higher tendency to rupture and cause massive bleeding. Okay. Right. Syphilitic aneurysms. Syphilitic aneurysms are very rare. I have already told you, but how does the ascending or the arch of the aorta gets weakened and causes syphilitic aneurysm? I hope you remember for your chronic inflammation lectures, I said, I don't know whether it was me, anyway, they get mesoaortitis. The cardiovascular syphilis is characterized by having mesoaortitis, where the aorta is supplied by vasa vasorum, and there will be inflammation involving the vasa vasorum, and we call it periarteritis, so that when there is periarteritis of vasa vasorum, there's blood doesn't flow sufficiently and causes ischemia, local ischemia of the media of the aorta, right? So media is thick and it needs blood. So what happens is, that's the aorta, that's this upper part is the intima. Now vasa vasorum is, if that is the vasa vasorum, because of inflammation, the lumen gets narrowed, so that these parts, some parts of the media doesn't get sufficient blood supply, so it becomes ischemic. Now, shall we say like these areas or whatever? As a reaction to that ischemia, there will be thickening of the overlying intima. So if you see it on the surface, you will see this is the surface patches of intimal thickening. And when it progresses, they become coalesced with each other. So there will be intimal thickening which occurs in a very irregular pattern, and through macroscopically it appears as like a bark of a tree. We call it tree bark appearance and intimal thickening, which is resultant in syphilitic aneurysm. And then going back to the same phenomena. Now, because of the ischemia, some of the areas in the media doesn't get sufficient blood and they undergo fibrosis, and there will be weakening of the vessel wall. It's not, it's fibrotic, and the medial muscle, the smooth muscle get disappear in areas, so that the vessel wall gets weakened and it gets dilated like this, right? So that's how a syphilitic aneurysm is formed. So if I show you a picture of of the aorta in syphilis, which is called tree bark appearance. Let me stop share and find another one. Yeah. This is a book called Rubin's Pathology, another textbook, which has this syphilitic aorta. The thoracic aorta is dilated and its inner surface shows typical tree bark appearance. If you just think of the I mean, when you're walking around, you see enough and more trees. No, like it's this because of this intimal thickening, right? So that's what is called tree bark appearance. Okay. Now, unlike atherosclerotic aneurysms in the aorta, syphilitic aneurysms in the ascending and the arch of the aorta can cause pressure effects. One reason is now this part of the aorta is within the mediastinum, so it's a very confined cavity and a confined area, very small, and whatever the enlargement that occurs in the aorta or any other structure can cause mediastinal compression. So these patients can present with superior mediastinal compression. You can go through your textbook in medicine or surgery. You will identify what the causes and other causes and how they present, and then it's quite near the bronchial bronchus. Therefore, it can cause bronchial obstruction, the syphilitic aneurysm, and it can compress upon the left recurrent laryngeal nerve. Therefore, paralysis of left recurrent laryngeal nerve is another presenting sign, and then it can rest upon the vertebral body, which causes vertebral erosion. And you know the esophagus is also going down near around this area within the superior mediastinum, so that they can get dysphagia. So pressure effects of syphilitic aneurysm is more than pressure effects of atherosclerotic aneurysm. And remember, it's very rare nowadays. Right. Other types of aneurysms are infective aneurysms, or we call them mycotic aneurysms. Generally, they are small. These happen because the sometimes wall can get impacted by infective emboli, and that causes infection there and causes weakening of the vessel, and that weakened area can dilate. Let me check what question that has been asked. So whether mycotic infection cause aortic incompetence. It may, mycotic aneurysms, it may, but may not be as common as you think. It's not a mycotic infection. I think this is something to do with your mycology you're asking me. I'm talking about mycotic aneurysm, or it is called infective aneurysms, right? Then cerebral aneurysms, I have already told you what kind of aneurysms can occur in the brain. The common one is Berry aneurysm. Then due to atherosclerosis also, some of the arteries within the brain can dilate and form aneurysms. Then hypertension. In a patient with hypertension, they can have Charcot-Bouchard aneurysms developing within the brain, and all these can cause intracerebral hemorrhage. Atheromatous also intracerebral hemorrhage, and sometimes subarachnoid. Berry aneurysm typically causes subarachnoid hemorrhage. And there's another entity called cardiac aneurysm. That is we'll be talking about this in the lecture on ischemic heart disease. Now, if an infarction, shall I say, this is the heart, that's the left ventricle. Supposing somebody get infarction there, but he survives, right? So when he survives, it is replaced, this area is replaced or repaired by fibrous tissue. What happens is, this is a high pressure chamber during systole. The pressure is exerted upon the wall of the ventricle in a similar manner along this the healed infarction. But unlike this, the wall, the muscular wall, this fibrous wall, because of the pressure, slowly get expanded. It gets stretched out and expand and form a bulging like this, right? That is called a cardiac aneurysm. We'll talk about, and I'll explain it better when it comes to ischemic heart disease, right? Then capillaries, tiny capillaries can have tiny aneurysms, especially in diabetic retinopathy. The ophthalmologists will look at the retina through the ophthalmoscope and detect retinopathy, whether in long-standing diabetes, patients with long-standing diabetes, they check the retina for retinopathy. One change that they see is tiny they are called microaneurysms. Okay, so that's all about aneurysm, and there is another thing called dissection, arterial dissection. Your old books would talk about dissecting aneurysms. No longer we use this dissecting aneurysm term, but we call it dissection, arterial dissection or aortic dissection, because it's not a true aneurysm. What exactly happens is there can be a tear in the intima which leads to tracking of blood into the arterial media, and it splits the arterial media, causing blood tracking down. So I'll show you another better picture of it. Just hold on for a couple of minutes until I find it. Okay, have a look at this. Can you see this book? Yes or no?
Yes, madam.
Right. So look at this. What actually happens is, due to a tear that appears over the intima, now these are three situations where dissection can occur. Blood tracks into the media, and now it is pumped out at a high pressure now, so it tracks down, splitting the aortic wall like this. So you have your normal lumen, and there's outside that, within the media, there's another lumen which contains blood. Sometimes due to the pressure, it can break back into the intimal layer, or it can break out there, causing bleeding into the mediastinum. Right? So when there is a dissection like that, there's one lumen containing blood, another lumen containing blood, and we call it a double barrel aorta. Right? The initial tear sometimes may appear in the ascending part of the aorta before your pericardium get attached to this or blends with this wall. Right? So then if at the very early part of the ascending aorta, if a tear appears, blood tracks down into the pericardial sac, pericardial cavity. And so this is going at a high pressure, and this also goes down in a high pressure, filling the pericardial, potential pericardial cavity, so that it compresses upon the heart and it restricts its contractions and expansion, which is called cardiac tamponade. Cardiac filling impairs. Cardiac filling is impaired, cardiac contraction is impaired, so it is called tamponade. So you are left with a hemopericardium if that happens. If the tear appears one up there and then comes again back into the lumen, then only you really get the double channeled or double barreled aorta. That's the entry point in the intima, and the exit back into the lumen is here down there. So if you get a cross section like this, you get two lumina filled with blood. Here it's a large one, and sometimes it can break through out there like this, causing massive bleeding into the mediastinum. Right? So these are not true neoplasms, true aneurysms. So the tear appears in the intima, which leads to tracking of blood into the arterial media. Generally, it splits between inner 2/3 and the outer 1/3. That's where it is a little bit sort of weaker, right? Its most common site for dissection, arterial dissection, is aorta. This is the normal intimal and the luminar, and these are the accumulated blood within the media. Now it looks like a double barrel aorta. Can you see what's the cause of this dissection in this case? Anybody? You can see that the intima of this aorta is very irregular, right? And it is atherosclerotic. So atherosclerosis weakens intimal tear may be due to the atherosclerotic weakening of the intima, right? So atherosclerosis is a common cause of aortic dissection as well. Now this is a microscopic section. Now I said generally the tear is between the inner 2/3 and the outer 1/3 of the media. So you see, this is microscopic appearance of the aneurysm dissection rather. It's the dissection and it's the normal lumen. I hope you understood what I'm talking about. Right. So this is at a post-mortem. There's a tear here, right? Now that's the ascending aorta. These are the semilunar valves. So it's an aortic dissection. These are the openings of the great vessels. Right. Which had it been now, here it is a little up there. Had it been somewhere down, this would have been the case. Now that's the pericardial sac within which you see blood. So this is an aortic dissection. May lead to hemopericardium when blood dissects through the media proximally. Such a massive amount of hemorrhage can lead to cardiac tamponade. Right? Does the blood pressure cause formation of the pocket-like structure between media and intima? Generally not. It may bleed into that, but it will not cause a proper dissection. If you're saying dissection, it's within the media. Right. What are the predisposing factors for arterial dissection or aortic dissection? Hypertension. 70% of the patients have hypertension. So because of pressure, it can cause intimal tears. Then myxoid degeneration in the media. This is a very well-known phenomenon. I hope you remember your degenerative changes that you talk about. Myxoid degeneration is one change that occurs in some of the tissues where the mucopolysaccharides, more and more mucopolysaccharides are deposited, and so they are not so strong. And through those areas, dissection can occur. So common examples are the Marfan syndrome and Ehlers-Danlos syndrome. Then atherosclerosis is also predisposes to arterial dissection. And another iatrogenic one is you have seen a lot of cannulation or instrumentation done through arteries to do a lot of manipulations within the heart. If that cannula goes wrong way, it can damage the arteries. So they are very careful not to do any damage. Commoner among males, but females become more prone to get dissection during pregnancy, because during pregnancy, a lot of proteoglycans can get deposited within the arteries, causing weakening of the wall, so that those weakened vessels can have an intimal tear and blood can track into those areas, causing dissection. So how are they sort of, if there is an aortic dissection, the patient will complain of tearing pain in the chest, right? Very classically, they say tearing pain. Then, since blood doesn't go down, they will have loss of peripheral pulses. Patient may have hemopericardium if the blood tracks down, if any intimal thickening occurs in the ascending aorta and blood tracks down, then it can rupture and cause massive hemorrhage, and the patient can just drop dead also. Right, double-barreled aorta, those are the effects. Right. Then hypertension, the pathology of hypertension, I'm not going into great detail, but you need to know the medical side of it, the types of hypertension and what the cutoff and what the complications are. I'm mainly concerning about the pathology that you would see. This is the most common cause of cardiac failure and major risk factor for atherosclerosis and major risk factor for cerebral hemorrhage. And you can divide hypertension into two types: benign hypertension, or sometimes called essential hypertension, where there's stable elevation of blood pressure over many years, and accelerated hypertension within a very short period. There's a very high elevation of blood pressure and have a lot of effects on the patient's health. When you take primary or essential hypertension, in 90% of the cases, you don't know the cause, but you diagnose it by excluding the other causes. Secondary hypertension is secondary to some other cause, and out of all patients with hypertension, 10% of patients are due to another effect of, or rather secondary hypertension, secondary to some other cause, right? due to identifiable cause. So why do you get essential hypertension? Cause is unknown, but probably a multifactorial pathogenesis, maybe genetically susceptible, or excessive sympathetic nervous system activity, or maybe there are abnormalities of sodium potassium transport system, and high salt intake. They say high salt intake is a cause of hypertension. Then there are abnormalities in the renin-angiotensin aldosterone system. So these are hypotheses that have been put forward. So essential hypertension is that. Secondary hypertension most commonly occur due to renal diseases, probably CKD, diabetes, maybe diabetes causing CKD, renal artery stenosis, glomerulonephritis, then endocrine causes like adrenal tumors, Cushing syndrome, coarctation of aorta, and many other drugs can cause hypertension. So read your medicine book for that, please. Is accelerated and malignant hypertension are the same? Yes. Accelerated hypertension, sometimes called malignant hypertension, and the other type one is called benign, or else primary and secondary is due to the causes. But benign and malignant are depending on your the amount of elevation of the pressure, right, and the duration. So the benign hypertension, pressure rises over a long period of time and it's not very high. But malignant hypertension, pressure rises over a short period and it's quite high, right? And the effects are also very, very significant. So what are the pathological changes in the vessel wall in benign hypertension? Changes are like what you see in old age. It becomes more pronounced due to hypertension. So you will see hypertension, we call it hypertensive arteriosclerosis because there is thickening of arteries. And if you separate it out in the arterioles, you see hyaline arteriolosclerosis, which I have already, I think I told you, no? Or else, arterial walls are thickened due to vascular or plasmatic leakage into the vessel wall, and the vessel wall is hyalinized. Not only the wall get hyalinized, but it sort of obstruct the lumen, so there is ischemic effect due to narrowing of the arteriolar lumen, right? So that's what happened. Hyaline arteriolosclerosis occurs in arterioles. The large and medium-sized vessels in hypertension also get long-standing smooth muscle on a long-standing basis. Smooth muscle cells get replaced by collagen and other proteoglycans, so that vessels are dilated and elongated and starches. These are the changes that you said with aging. I think I did with aging, and with aging happens, but it gets accelerated in patients with hypertension. Can we observe atherosclerosis in placental vessels? In placental vessels, in pregnancy-induced hypertension, there's kind of sclerosis, but it's not like what you get in the rest of the vessels, atherosclerosis. A little bit beyond your scope, but atherosclerosis we don't say occur in what we have been describing in placental vessels. There is a different kind of sclerosis that occurs, right? So benign hypertension, continuing with that, small arteries shows concentric intimal thickening and atrophy of the media, and arterioles, hyaline arteriolosclerosis. This I have already told you. Hyaline arteriolosclerosis is due to deposition of plasma proteins. So, so these are the changes that we describe for aging, and they completely get accelerated with hypertension. Then just a picture. This is an arteriole with hyalinized wall. So hyaline arteriolosclerosis, which increases the rigidity with limited capacity for expansion and constriction, so that they are not very responsive to your vasodilators or whatever the drugs that you give them to control blood pressure. Then reduction in lumen size is a problem because it causes ischemia to the area supplied by these arterioles. Now, what are the changes that you see in the vessel walls in malignant hypertension or accelerated hypertension? Both are the same. Right. they are more pronounced and more damaging than in benign hypertension. The hallmark is fibrinoid necrosis. Now, necrosis is what you know that. Fibrinoid is now OID means fibrin-like. So there is some fibrin-like material getting deposited with necrosis. So you call it fibrinoid necrosis. That happens in malignant hypertension. So it consists of necrosis of smooth muscle cells in the media, and plasma getting insudated into the artery so that it contains fibrinogen and becomes fibrin. And when the vessel wall is damaged, there will be hemorrhages. So classic features are there are focal fibrinoid necrotic areas in the arterial wall with resultant tiny hemorrhages. This can be well visualized in the kidney. In malignant hypertension, kidneys, we say, look like flea-bitten, like a small creature has sort of eaten up everywhere over the surface of kidney. Appears like that. So we call it flea-bitten appearance in the kidney in malignant hypertension. That is due to tiny infarcts, due to obstruction of the walls and tiny hemorrhages, right? When there is fibrinoid necrosis in the vessel wall, obviously there is thrombosis because the vessel wall has got altered. No? So with the thrombosis, there will be tiny infarcts because of loss of blood supply. And at the same time, okay, sorry for that disturbance. Right, this is what we say fibrinoid necrosis. Now you can't see the wall, it has got disrupted, there's fibrin-like material which has got deposited in the wall, and that's blood. So when the wall is not strong, now it's disrupted, no hemorrhages can occur. This is the appearance of flea-bitten kidney in malignant hypertension. Right. There's another change that can occur in the arteries in malignant hypertension. That is called hyperplastic arteriolosclerosis. Sometimes we call it proliferative endarteritis also. Sometimes it's called onion skin arteritis. All what means is that this is a very prominent change that occurs in malignant hypertension in vessels. Now, what has happened here is that's the vessel wall, and you can see a thickening, which is like a skin of cut onion. Concentric layers of cells have deposited, intimal cells have proliferated, and it appears like an onion cut across. And it causes narrowing of the lumen as well. So if there is narrowing of the lumen, you are sure to have some ischemic effects also. Now, so that's why sometimes it's called onion skin endarteritis or proliferative, because cells are proliferating. Endarteritis because it narrows the lumen and causes complete occlusion sometimes. Hyperplastic vasa because there's a proliferation of cells, right? So there are so many names given, but don't get this thing, all that means the same. Vascular change that occurs in malignant hypertension. So fibrinoid necrosis and hyperplastic arteriolosclerosis are very classic changes that occur in malignant hypertension and in the vessels. This change is very often seen in the kidney, the renal, interlobular arteries, and causes severe narrowing and causes ischemia to the area supplied by that artery. Right. Any questions on the arterial changes? Okay. So hypertension can cause changes in other organs also. In diabetes, you do not see hyperplastic arteriolosclerosis unless there is malignant hypertension. What diabetes causes is just like what you get in benign hypertension and what you get in aging, right? So aging process, changes in the vessels that you get in aging are pronounced or more severely seen in diabetes as well as in benign hypertension, right? So hyperplastic arteriolosclerosis does not occur in diabetes unless there is malignant hypertension. You generally have these patients having everything, no? So sometimes you find that also. Right. Because of hypertension, what can happen to the heart? The left ventricular hypertrophy and left ventricular failure can be seen, right? You know why? Because when the pressure is high, the heart, the left ventricle has to pump blood with some efforts, which causes hypertrophy of the left ventricular myocardium. Then, due to hypertension, intracerebral hemorrhages can occur. And sometimes because of these intracerebral hemorrhages, they develop tiny infarcts called lacunar infarcts. You will learn this more when you do your CNS lectures. Then in the kidney, in benign hypertension, it causes arteriolosclerosis, hyaline arteriolosclerosis, and due to ischemia, they develop, you call it nephrosclerosis, benign hypertensive nephrosclerosis, you call it. We'll be talking about these changes when we do renal pathology. In the aorta, it predisposes to dissection as well as development of atherosclerotic plaques. Right. Few things about vasculitis. I don't know whether, sorry, just skip it, no? Sorry. I have missed one slide, right? Okay. Just a little bit about pathological causes and physiological changes in pulmonary hypertension. I told you pulmonary vasculature is a low pressure system, so that unless there is pulmonary hypertension, you do not see atherosclerotic plaques in the pulmonary vasculature. But the pulmonary vasculature can change depending on the reason or the cause. So if you take acute and chronic left ventricular failure, left ventricular failure, if progresses, can cause increased pulmonary venous pressure, right? And therefore, pressure within this system can increase. Then mitral stenosis in a similar manner can cause increase in pulmonary venous pressure. So chronic bronchitis, bronchial emphysema, and these chronic lung diseases causes hypoxia, and therefore pulmonary vascular constriction is seen, which causes increase in pulmonary venous pressure. Then if there are recurrent pulmonary emboli due to some reason, then again the pulmonary resistance go up and they can have increase in pressure. There's another entity called primary pulmonary hypertension, where there is raised pulmonary pressure. In these situations, they might develop, depending on for how long it has been there and how much high the pressure is, they are prone to develop atherosclerotic plaques. Right. So you need to know about vasculitis also, not in great detail, but this is more clinical thing and you need to know clinical aspects of it. But pathology-wise, well, it is an inflammation of the vessel wall. That's why you call it vasculitis, and it can affect all types of vessels. Minor forms like there are different vasculitic changes which are very transient and the patient recovers quickly without much damage. But there are severe forms which can cause irreversible destruction of the vessel, and the patient will come with a lot of symptoms and signs. And vasculitis on etiology basis can be categorized into 3 categories: direct infection, immunologic, and unknown causes. And also vasculitis can be categorized depending on the size of the vessel which is affected. So large and medium sized arteries, when you're doing your medicine appointments, you will get these diagnoses in your differential diagnosis. The large and medium sized arteries are affected by giant cell arteritis, Takayasu's disease, and syphilis, and some other infections also. Medium sized arteries are affected in polyarteritis nodosa, Kawasaki disease, vaginous granulomatosis, Churg-Strauss syndrome, Berger's. Now, you will come across these terminologies when you do your medicine, but know that these are vasculitides. Arterioles and capillaries are inflamed in Henoch-Schönlein purpura, microscopic polyarteritis, serum sickness, Churg-Strauss again. Now, problem is when the vessels are inflamed, they are weak, they can cause hemorrhages and thrombosis also. Right. So what are the types of tumors that can occur within the vasculature? Hemangioma, that's a benign one. Then angiosarcoma is the malignant one. And hemangioendothelioma is a sort of in between, and it's a borderline malignancy. It's not as bad as angiosarcoma, neither is not as good as or benign as hemangioma. There's another entity called that is again a sort of a borderline behavior. It has Kaposi sarcoma, which often occurs in HIV patients. So read a little more about this. The pathology part is not that discard. Right. Okay. Questions from any questions? No? So we'll stop there. Okay.